So welcome to anybody who's joined already. We will get started in just a couple of minutes when we reach time. Again, welcome to anybody who's been able to join already. We'll get started in 1 minute's time. All right, I believe we have reached 1 p.m. Eastern. So welcome to everybody who's joined for the webinar today. We're very excited to be presenting to you from the Hamilton, Ontario, for at least some of us, which are on the traditional territories of the Mississauga and Haudenosaunee Nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. We are very excited to be presenting this webinar for you today as a collaboration between the National Collaborating Center for Methods and Tools and the SPORE Evidence Alliance. We have a number of presenters today who we will be introducing shortly. As everybody else is joining, there are a few housekeeping items. In terms of connection, if possible, we do recommend using a wired internet connection. If possible, the latest version of Google Chrome or Firefox internet browsers should work optimally. If you are experiencing any technical issues, Alana Miller from the NCCMT is available. You can send a private message through the Zoom client to her. You can also use the Q&A and chat to post questions or comments throughout the webinar. Please post your questions through the Q&A and make sure that anything about technical difficulties goes to a private chat to Alana, if possible. There are a few polling questions today in the webinar. When those open up, they will pop up over the slide on your screen. Please note there is sometimes just a slight delay with the polling questions popping up. And then once you enter your response, make sure that you hit submit so that your answer gets recorded. After today, the slides and recording of today's webinar will be available in usually about 2 weeks. The slides will be posted in English and in French on our SlideShare, and a recording, which is in English, will be available on our YouTube account. Keep an eye out on our Twitter account. We will make sure that we send out tweets when those have been posted. So we'll start now with some of our polling questions, just to get a sense of the audience that's with us today. We realize people have started congregating again. So is there anybody watching the webinar with you? We know that before COVID, we'd have people joining within teams within an office to join the webinar. So we just want to get a sense of how many people really are joining us today. We're also interested in if you are familiar with the National Collaborating Center for Methods and Tools, if you've used any of our resources before, and if yes, how often you have used those resources. Again, just to get a sense of the audience, and we can tailor things appropriately based on who's joining us today. So it looks like we have still most people joining on their own, about a 50-50 split between people who are familiar with the NCCMT and those who are not. So that's great. We hope that we can give you a great introduction to the center. And I will hit end the polling now. Thank you so much. All right, so just a very brief introduction to the National Collaborating Centers. The Center for Methods and Tools is actually one of 6 national collaborating centers across Canada. We are hosted at McMaster University in Hamilton. Our goal is to support public health professionals and organizations to integrate evidence-informed decision-making into their work. Each of the 6 national collaborating centers is funded by the Public Health Agency of Canada. So you can see from west to east, we have the Center for Environmental Health, Indigenous Health, Infectious Diseases, Healthy Public Policy, and Determinants of Health. And while each of these different centers focus on different topic areas in public health, here at the National Collaborating Center for Methods and Tools, we focus on evidence-informed decision-making in all areas of public health. So I'm very excited to present our panel for today. We have a really wonderful and broadly experienced panel joining us today. First, we will hear from Maureen Dobbins and Sarah Neal-Stramko from the National Collaborating Center for Methods and Tools. Maureen is our scientific director and a professor in the School of Nursing at McMaster University. Sarah is a knowledge translation advisor for the NCCMT and an assistant professor at McMaster. Dr. Andrea Trico leads the SPORE Evidence Alliance Pan-Canadian Research Initiative. And I will allow you to introduce yourself and your role a bit more as well when it's your turn. And on the other side, we have actually a number of panelists who have been part of the patient or public partnerships. So Maureen Smith is the chair of Cochrane's Consumer Network Executive. She's the co-lead for COVID and Citizen Partnership and a member of the SPORE Evidence Alliance. Her interest in evidence synthesis stems from a rare disease in childhood and her frequent flyer status within the healthcare system. Amanda Doherty Kirby is a caregiver to 6 young people ranging in ages from 7 to 20 with various diagnoses that have made navigating the medical and educational systems both frustrating and fascinating. She knows the importance of clear communication of evidence and joined COVID End in response to both the misinformation that she has seen in online interactions and her desire to use her lived experience to help others. Abu Dukuli is another member of the SPORE Evidence Alliance, and his experience stems from working with immigrant and newcomer populations. And to get us started, I will hand it over to Dr. Maureen Dobbins and Dr. Sarah Neal-Stramko for the National Collaborating Center for Methods and Tools.
Great. Thanks so much, Emily, for the introduction, and definitely welcome to everyone who has joined us, and including you, Lisa, getting up so incredibly early Australia time. It's great to have everyone with us. So I'm just going to give you really a very quick introduction to our short form for our name is the NCCMT. So we developed a rapid evidence service very quickly at the beginning of the pandemic. And there was an urgent and ongoing need for synthesized evidence, even in those first few weeks of the pandemic as studies started to emerge. But there was little to no capacity among the frontline public health service delivery organizations to be finding that evidence, appraising it, and making sense of what it meant to them. And so what we found was, given our long-standing relationship with public health across Canada, that decision makers at many levels, from local to federal or national, were turning to us to say, can you take a look at this evidence and tell us, basically what are the key findings across the evidence. And so we had the ability with our funded center to pivot significantly from the work that we normally do, which is to support the development of capacity to use evidence in decision making, as Emily pointed out. So to move from doing that to actually doing the synthesis ourselves. And really interestingly, in those very early weeks and months, the requests far exceeded our capacity to be able to answer those questions, but there was great demand coming. And the next slide, please. So I just want to give you a snapshot. We really refer to this as the relay race of our rapid evidence service, which we're trying to depict in that graphic down the right-hand side. But it really starts with prioritizing the questions that we received. And as I said, we were really receiving more requests than we could commit to responding to, and usually very rapid turnaround times. At the very beginning, we were trying to do our best to complete the evidence synthesis in 5 days. Then that transitioned several months into 5 to 10 days. And now usually it can take a little bit longer than that, depending on just how much evidence we're having to sift through. We're building off of an already established protocol that we had created for conducting rapid reviews. We had worked with the Public Health Agency of Canada previously to develop this guidebook and had made that available, and certainly needed to make continuous tweaks to the methodology as the evidence ecosystem in COVID has changed. But just really to talk a bit about the process, it starts with taking that request and defining and refining the questions that we've received so that it's answerable, then searching for the evidence, appraising the evidence. And that is something that our center has aspired to do in probably 95% of all of the rapid reviews we've done, has been to appraise the quality of the evidence as well. About 4 months in, we also started grading the evidence. We then synthesize that, and then we look at the applicability and transferability in terms of thinking about, for Canada, what makes sense to apply from that evidence to our context here. Next slide. And just a little bit around the prioritization. Again, we've also partnered with COVID, which some of you may be familiar with, which started right at the beginning of the pandemic as well, led by Drs. Jeremy Grimshaw and John Lavis, who really brought together more than 50 international organizations that were involved in evidence synthesis and involved in supporting decision makers. And through COVID, we have a coordinated system here in Canada whereby when requests are received for reviews, a call goes out to the network, and those who are able to take on that review at that time will put their hand up and then move forward. And so we've also been a part of that as well. And the team meets weekly to assess how we're doing with our current projects, as well as our ability to start any new reviews and sort of plan for the next few weeks. Number one, we're trying to avoid duplication. So we really look to see has someone else already answered this question, and is it current? Can we use that? And if one already exists, a review already exists, we would pass that along to the requester as opposed to getting started on doing the review ourselves. We try to assess if it's relevant and urgent to the Canadian context, and we also look to see, really seriously consider if we have the expertise to answer the question. If we don't, we really want to try to find someone else who does. Next slide. And I'll just pass this on now to Sarah to talk about the rest of the process.
Great, thanks, Maureen. So once we have the request, of course, the next question is formulating that question and defining it very clearly, so we know what evidence we're looking for, what evidence we would be including in the review, what we would be excluding. And we try to formulate our question either in the PICO, so population, intervention, or exposure, comparator, and outcome format, or PS format as much as possible, although sometimes due to the nature of the questions that we get in response to the pandemic, sometimes the questions need to be formulated a little bit differently. We always try to collaborate with the requester and with patient and public partners when possible. So as with all rapid reviews, we start with our gold standard of what we would like to do if we had all the time in the world to conduct a thorough systematic review, but of course, due to timelines, we need to take some shortcuts throughout. So, our struggle is always, where can we sort of cut a few corners without compromising the rigor of the review? So this has been one of the challenges for us throughout, is in some of these very tight timelines, can we collaborate meaningfully with both the requester who's looking for the evidence to make sure that we understand what type of decision this might be informing, what is it that they're really looking to understand, and then also to work with a patient or public partner where it's possible to help bring that perspective in to what questions are truly important. So sometimes we're able to do that very well, and other times that's not possible if the question has come to us already prepared from a decision maker and we need to move very quickly. So that's one of the steps that that we sort of that kind of is variable depending on the review that we're working on. And then we use that question to set our inclusion/exclusion criteria. And you can see an example of this on the right-hand side in our review of the roles of schools and daycares in COVID-19 transmission. Next slide, please. And then, of course, critical appraisal. We, as Maureen mentioned, we feel very strongly that it's important to critically appraise all of the evidence as much as possible that we include in our rapid reviews. So our critical appraisal is done by one member of the NCCMT team and then verified with us by a second reviewer. And any conflicts that come up between the two are resolved through discussion or with input from the review lead as it's needed. Sometimes the COVID-19 literature can be a little bit messier than our traditional scientific literature, so sometimes that needs a bit of conversation. We use a variety of tools to appraise the evidence depending on what the design of the study is. So we use AmStar1 for any systematic reviews that we include. We use the Agree-To tool for any guidelines. And then the Joanna Briggs Institute has a series of checklists for other study designs that we use for the rest of the single studies that we might include in a given review. And then each review is rated as either strong, moderate, or low quality, just for a simple way to convey that to the reader of the review. So one of the things that we have considered but haven't executed on yet is whether or not we could include patient and public partners in our process of critical appraisal. It's challenging to do in a very tight turnaround, but I know that's something that other groups have incorporated, and bringing that important perspective into the quality of the individual studies that are included, but not something that our team has explored yet. Next slide, please. And then, as Maureen mentioned, we do grade all of the evidence, which we started doing about 4 months into our rapid evidence service. So GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation. And really it's meant to help us answer that question: how likely are these findings to change if we were to include more evidence? So how certain are we in the findings, that the conclusions that we're drawing from the body of evidence that we have to date? So we rate the certainty of evidence based on 8 different domains, and that's the responsibility of the review lead. And so these are really methodological pieces around the risk of bias from our critical appraisal, inconsistency of effects, how indirect the interventions or outcomes may be, how precise they are, whether or not we believe there may be publication bias, the size of the effect that we see, whether there's a dose-response relationship, and then accounting for confounding. And then we rate those and give a statement based on whether we feel that the certainty of the evidence is very low, low, moderate, or strong. Okay, next slide, please. And then we have our final product. So we highlight the question at the very top, front and center, followed by an executive summary, which is usually about 1 to 2 pages in length. We try to keep it as short and concise as possible to highlight really what those key findings and the certainty of evidence are. So if someone is only going to read and take one thing from our review, it should be up front and center for them to easily access. If this is an update to a previous review, then we have a section on what has changed or been updated, and then an overview of the evidence overall and any gaps that exist. And that's followed by our methods and the results and tables. Next slide, please. So this is, again, a little bit more detail around the executive summary. And so far in our process of incorporating our patient and public partners into our rapid evidence service, this is really where the strongest contributions have been. So early on in the pandemic, as we were answering these questions in sort of a 5-day turnaround, we didn't have the opportunity to incorporate any other perspectives into our rapid reviews. But as their timelines have extended out a little bit, and we've been connected with Dr. Trico and the SPORE network and the Cochrane group, we've been able to access and connect with our patient and public partners more meaningfully. And this is where we've really been able to incorporate those perspectives in this executive summary, helping to refine, and especially in the overview of evidence and knowledge gaps section. Next slide, please. Oops. Just need to go back to, I have one more slide. Thank you. So some of the things that we struggle with in our team, particularly in the context of rapid reviews where we have a very tight turnaround, is how to make sure that we're meaningfully engaging with our partners in the short timeline and sometimes with changing deadlines. So how do we, what kind of process should we work for to make sure their perspectives are meaningfully incorporated and it's not just a final sign off at the end of the process? And what are the most important steps in the review to incorporate their perspectives within? So as Maureen highlighted, we sort of have this relay race. So where are the most important points that we need to make sure that we check in with our partners so that we're not missing anything? We also recognize that they are either volunteering their time or have many other commitments on the go. And so while this is sort of our full-time job, this is not their full-time job. So asking someone to turn something around in, an hour or two with short notice is not really respectful of their time. So how can we make sure that we do this in a meaningful way? How do we appropriately incorporate their input into the executive summary, particularly in reviews of qualitative studies? How do we make sure that those voices are heard without inappropriately identifying people's individual perspectives? And how do we make sure that in this whole process that our partners are feeling supported and empowered to participate meaningfully, make sure that they feel comfortable voicing their opinions, and even in times that they may disagree with how we've interpreted the evidence. So these are the things that we're struggling with internally, and would love to engage in some conversation with other groups who have more experience working with partners in rapid reviews as we get towards the end of the session. So with that, I will turn it over to Dr. Trico.
I'm on mute, talking to myself. Thank you so much for such a great overview of the NCCMT and all the important work that you're doing in rapid reviews. It's such a pleasure to be here today, speaking with everyone and speaking with my colleagues from the NCCMT. I will open my screen now. I always have a little difficulty doing this. Okay, great. Okay, can you see my screen okay? Yeah, okay, thank you. Excellent, so thank you so much, and I really love the focus on the methods for rapid reviews. So I'm gonna switch gears just a little bit and talk mostly about patient engagement in the strategy for patient-oriented research, or SPOR Evidence Alliance. So I'm gonna talk about how we've been engaging patient partners throughout different activities and in the rapid review process. And I will note that I'm going to stick with the term patient engagement, which is according to the CIHR SPOR, or the Canadian Institutes of Health Research SPOR, which funds the SPOR Evidence Alliance. But just to note that it is a very open term. So we would include patient partners and their formal and informal caregivers, as well as we would also include the public in there, so citizens, and very, very broadly. So we're trying to be very, very broad with the term patient. So when I say patient, I mean it in the broadest sense. So here is my acknowledgement of traditional land. So just to note that where we are located right now, it was traditional territory of many different groups, so including the Mississaugas of the Credit, the Chippewa, Ojibwe, Anishinaabe, as well as the Haudenosaunee and the Wendat. And just to also note that this is coming from the Dish with One Spoon Treaty, which is very, very beautiful. And so it's where they're opening up and welcoming everyone to share the land in the spirit of peace, friendship, and respect. And just to position myself as being a European settler, and most of my family is in Northern Ontario, so I'm kind of the black sheep of the family to leave and come to Southern Ontario. So just to note that we are just incredibly humbled and grateful to have the opportunity to work on the land that we do. So in terms of conflicts of interest, so I don't have any financial competing interests, but I would say I'm incredibly passionate about this. And so I definitely have some academic conflicts of interest because this is an area that I hold really close to my heart. So just to give you a background about how the SPORE evidence lines came to be. So in 2011, the Canadian Institutes of Health Research released the strategy document for SPORE, and they were looking for a coordinated national activity or initiative that would help with knowledge synthesis, knowledge translation, and guidelines. And in 2016, a funding opportunity was released, and we were very fortunate to join 175 researchers, trainees, patients, and decision makers from across Canada and beyond to submit a grant application. And then we were quite fortunate to be the selected team to move this forward in 2017. So in terms of what we do knowledge synthesis, guidelines, and knowledge translation, and everything has to be for decision makers. So I would say that the majority of our products have been in knowledge synthesis, and many of them have been rapid reviews because that's what decision makers seem to request. Although we have provided support for guidelines, and we have also provided knowledge translation support. So we are at 348 members and counting. I think we had like 2 or 3 new members this week. We are open arms. We welcome everyone. Everyone is welcome to join. It's free of charge. And there's a lot of benefits to joining, which if you're interested, we have a whole nice little list of why you may want to join the SPORE Evidence Alliance. So we'd encourage everyone to join. And we're very diverse. So we about 50% of us are researchers, but we also have about 20% trainees, about 20% decision makers, and then about 10% of patients in the public. Similar to my colleagues from NCCMT, how they were talking about how do we receive requests. So people will be submitting research questions to us either using an online form, or they will contact us directly. So myself, some of the other PIs, or the central office. And then we work with them very closely to refine the scope and ensure that it is tailored to their needs. And then we match them up with a research team across the country to adequately address the query. And we try to use integrated knowledge translation. So that's where our decision-making partners are integrated throughout the research process. So we would engage our patient partners as much as possible throughout every step, which brings challenges that we're doing with a rapid review when we have such a quick turnaround. And then also to say that we also accept requests from patient partners, which I'll get to in a few slides. And then we try to tailor our knowledge products, tools, and all of our dissemination activities towards our decision maker needs. So our goal was to address 100 queries over the time frame, and we've surpassed that. And just to note that we've been able to engage 194 decision makers, 180 patient partners, and 95 trainees. So we strongly believe in training the next generation of scientists in this work. So we try to embed a trainee on all the projects as well. And to note that we've been fortunate to have 18 amazing research teams. They're like family to me. And so I love them dearly. We work super closely together, and they've all agreed to take on projects, sometimes with very, very short timelines. So I'm incredibly indebted to all of them. And send a huge thank you to all of the teams that have taken on queries through the SPORE Alliance. So another thing that we're proud of is that we try to be very diverse in who our audience is. So we've actually worked with 45 different organizations at the provincial, national, and international level. We also have 11 patient partners who submitted queries, and we prioritize those queries. And something we're super excited about is that those 3 queries that we prioritize with other decision makers to ensure they have a very broad impact will actually be co-led by a patient partner and a researcher. So we're really excited about this, and I think it's going to be a really fabulous experience by the patient partners co-leading it as well as the researchers. We've been focused, as Dr. Dobbin said, we pivoted to COVID quickly. We did join forces with COVID end as well. And so there have been 37 requests that have come through. And again, as Dr. Dobbin said, 5 to 10 day business day turnaround. Back in the day, it used to be a 3-month turnaround, and now we've moved to 5 to 10 days. So really sped things up. And we try to engage patient partners in all of them. Just a quick note that we do promote open science, and we also encourage publication by our patient partners. So as much as possible, we have our patient partners as co-authors, and now we're moving towards our patient partners actually as being first authors, which is also incredibly exciting. We provide training opportunities to trainees and patient partners. I know that Maureen Smith will be talking about our course that we provided on rapid reviews to our patient partners, so I won't provide details, but just a huge shout out to Maureen Smith and Janet Gunderson, who led that. So our patient partners actually led the course and told us researchers what to do when, and they did a fantastic job. We've also done some work with Indigenous populations so that we can continue working together and working on really important topics. So throughout, you've kind of seen a snapshot of how we've been working with patients. So I just wanted to put this in one nice summary slide. So we engage our patient partners in our governance committees, and we also include them as co-chairs on the committees. We co-develop our policies with patient partners. We invite them to be peer reviewers with a focus on impact and relevance in the seed grant competition. We also accept patient partner queries, as I said, and then if those ones are selected or prioritized, then they are able to co-lead that, and that will lead to further publications. And then we also had the training that we provided for rapid reviews. So to switch to specifically now to rapid reviews, so we do have some resources as well. So we've provided some documents, and we've conducted several webinars, and again, trying to get to meaningful patient engagement, as our colleagues from NCCMT mentioned. So how can we meaningfully do this? And we also really focus on trying to encourage patient partner appreciation policies. So this was co-developed with our patient partners to make sure that we adequately compensate them for their time. So every time that they engage with us or help with any activity, we want to make sure they're properly appreciated. We also have some methods guidance resources, and in those resources for researchers, we also give some tips and tricks on how to engage patients and the public in our rapid reviews. So I provided a couple links there, definitely check it out, and we're always looking for feedback on our resources, so let us know. And just in terms of, you know, some of the lessons learned would be that we need training, and from my experience, and you know, to the researchers in the audience, don't be mad at me, but I feel that researchers need a lot of the training. Like, the patient partners are great. I mean, you researchers are great too, but researchers, I think we struggle sometimes with our type A personalities and wanting to do everything perfect. So I think more training and more capacity building for researchers would be great. Also trying to engage more than one patient or public partner on each project. So we don't want them to be the lonely only patient. So trying to ensure that they do have a voice, and making sure that, you know, if they have a partner there, then hopefully that will give them will allow them to feel a bit more comfortable. So you want to engage them at the very start, so right at conceptualization as much as possible. And I already mentioned fair compensation, creating a positive, inclusive environment. Something that we've been pushing for is how do we acknowledge our patient partners on the rapid reviews? So making sure that they're actually named. I know it sounds something simple, but Maureen Smith is great at saying, oh, your products don't always have patient partner named. Patient partner's name. So making sure we have that. And then I love the NCCMT example to have a little patient partner corner in the executive summary of findings. So it's front and center. I think it's super important. And then minimizing some barriers. So making sure we're not tokenistic, trying to establish time for building trust and respect. I know it's challenging in rapid reviews. And etc. I don't want to talk anymore because I don't want to feed into the patient and public partner section. So I am just going to say a huge shout out to our funding acknowledgement, as well as to COVID-END, who did provide the Square Evidence Alliance teams with funding. Want to thank all the principal investigators across the country, and want to thank my amazing staff, who I love dearly. So with that, I will now pass the torch on to Maureen Smith.
Thank you, Andrea. Maureen, I will get your slides either up. Get your slides.
Thanks, Emily. While you're doing that, I'm embarrassed my land acknowledgement didn't make it into my presentation, so I'm just going to put it into the chat. So I want to acknowledge that Ottawa, the land on which I live, is the traditional unceded territories of the Algonquin nations. The Algonquin peoples have lived on this land since time immemorial. And I'm making this statement to acknowledge that I'm grateful to have the opportunity to present in this territory. So hello, everyone. Great to see so many people. And I'm going to, you've heard the researchers, so now you're going to hear from a couple of patient partners. And I'm going to start off really briefly and talk to you a little bit about my experiences partnering with citizens and COVID and evidence synthesis. So I'm going to backtrack a bit to the beginning. So when COVID-N was started, I was on a knowledge translation committee, advisory committee with John Lavis at Cochrane. He was talking a lot about it and we were hearing all about it. It was all very exciting. And he's going to say I nudged him, which is a very polite term. He's a very polite man, but I kept saying, oh, you know, citizens are making decisions too. Your whole purpose is to support decision makers. Well, we're making decisions too. And he said, oh yes, Maureen, that's true. And of course, you know, open your mouth. And the next thing you know, you're co-leading the COVID-N Citizen Partnership. So that began in August of 2020. At that time, it was a global strategy and we tried to get global partners. So we weren't involving them in evidence synthesis per se, like what the Canadian group did. It was really in the governance of it, in joining all the different task groups, all the different committees, and getting them integrated into it. And we recruited citizens from all over the world for this. And then in January of 2021, we received our funding for COVID-N in Canada from CIHR. And oh, what an opportunity that was. So that's where I kind of began really working closely at that point with Andrea Trico from the Sport Evidence Alliance. And I've collaborated with Maureen Dobbins and her team. And I've made all these friends along the way. And really, it really is a group effort. A lot of what I do is collaboration. So that's been really interesting. Next slide. So very generally speaking, you know, why would you want to have citizen partnership? So for COVID-N, we talked about citizens. In the citizens, you know, it's really members of the public, and we include patients and caregivers in that too. And that's because of the public health, you know, slant of COVID-N, whereas traditionally, you know, in CIHR, we talk about patient and partners, we talk about patients and caregivers and all of the people who are with them. When the pandemic came, there's this now all of a sudden every person in society is being affected by it. So those partnerships had to be there. So basically, very generally speaking, you know, the topics were relevant to citizens. I'm talking about the public health measures, the vaccines, all those societal economic impacts. As I said before, my main impetus was that we are decision makers and that we're making personal decisions have a tremendous societal impacts, sometimes without the right evidence. Generally speaking, citizens can help shape research to be more responsive to the needs of Canadians, like focus on their priorities and relevant outcomes. You'll see when you get to rapid reviews, that's more difficult to do because the question is often very clearly defined by the funder. So that whole, you know, aspirational goal of shaping research is still there, but it changes when you're looking at rapid reviews that are, you know, have a specific question. And then of course we have this unique knowledge that can help interpret and contextualize research, the research that's being done. So that's what I was committed to engage in citizens in COVID-N. Next slide. And then to make that leap to engage them in evidence synthesis, oh my, and especially rapid evidence synthesis, we set up the program and then I crossed my fingers thinking, is anyone going to go for this? Are any of these researchers going to contact us? Luckily, they did. So basically, evidence synthesis is really the backbone of those policy decisions, those clinical guidelines, the good practices, and we are the end users. So we should be engaged in prioritizing rapid review topics when that arises, framing those questions and having input on the outcomes, interpreting the findings to make them relevant, and then accessing the results in plain language. I can say that the pandemic created this incredible opportunity as not only patients, but the general public were immersed in this whole evidence world. And there's this renewed interest in science. So it's very exciting for me, from my perspective as a person who champions co-production of evidence synthesis and making it accessible to patients, caregivers, and the public. The issue is that the evidence system ecosystem is complex and not public friendly. So I'll tell you how we kind of try to get around that. And that most patient partners, which is very advanced in Canada, are not engaged in evidence synthesis products. And even in systematic reviews, they usually come in at the end as peer reviewers. So, wow, it was a huge order. And I can tell you frankly that we really had no idea whether we would get a single person matched. Next slide. So basically, when you're looking at the challenges, is that quick turnaround time. So some projects within 5 to 10 business days, no time, not enough time to train the researchers themselves and the patients and citizen partners on how to meaningfully collaborate. And it's difficult to build those relationships with these rapid projects. So we tried to find challenges. Like in Canada, we have many resources for patient-oriented research, and we've made great strides in that area. The focus is not really on citizens though, and a lot of the best practices don't really apply to working in that so quickly. So Amanda is going to talk about some of the challenges from that perspective. So I'm not going to go on for too long about that, but I will talk a little bit about some of the solutions that we had for that. So next slide. So one of the solutions was to recruit people and hope that we'd be able to match them with researchers. And wow, we sent out a call, and within 2 weeks, 80 citizens had applied. Most of them had no experience with participating, in evidence synthesis. And so we chose about 20 people from that group. We had really good diversity and, by age and gender, pretty good for geographical was really good also. And then, so we created this pool, and then we provided some training. Next slide. And entered Andrea Trico, who said, Maureen, and you and another patient partner, how would you like to co-create a rapid review course? Oh my, I couldn't believe it when she said it. And then of course, so we did that. We worked really hard, really quickly to get this 10-hour course going. And then she said, how would you like to invite your COVID and citizens to join the course? So I thought I had won the lottery at that point. I kind of had to pinch myself. Did I dream that? So we had 24 people, a mixture of more experienced patient partners who were already part of the Spore Evidence Alliance, and then we added another 10 of our citizens who are interested, and we created this course, this 10-hour course. And the whole goal of it was to give enough information so that they could participate, but really put the whole emphasis on what their role would be and how important it was and how it would work, and be as realistic as possible so that we didn't set these expectations that researchers would not be able to meet. So we delivered this course, and it was well attended. People stayed right until the end. I remember after the first week thinking, oh, they've all come back. So that was a huge boost. And I can tell you now that we have, of the 24 partners who took the course, 21 have been engaged so far, so matched with teams, and some have been engaged more than once. And in our own pool, we've only got 2 people remaining who we haven't been able to engage. So all of my worries about nobody coming, well, that turned out to be worrying for nothing. So I'm almost at the end. My next slide. So we try to create some tools. So this is a citizen engagement request form for researchers. And it's a tool for the researchers to kind of get their thinking around what it is that they want to do, but it's really a tool also for the patient partners. When we send out a request, COVID-N asks for an answer within 48 hours. So you've got 48 hours to read the email and decide if you want to do this. So we try to get as much information in as possible. And so that was one of the tools that we've no one has refused to use it. Everyone uses it. And I think it's a way of trying to make it as feasible as possible, so that people don't sign up for something and find out later that those dates just don't work for them, because there really isn't any flexibility. My last slide, Andrew's already talked about an appreciation policy. If you're in this to make money, you're barking up the wrong tree. But we do have an appreciation policy, and we do pay for the work that the people do. We do offer some compensation, and we feel that that's really important, and that's worked really well. I'm going to stop there so I can let Amanda share her experiences with you. Thanks a lot.
Just a minute here and I'll share my screen. And I hope everybody sees that. I've made some, first I want to acknowledge that I'm zooming in from the traditional and unceded territories of the Abequit-Mi'kmaq First Nation. I'm in beautiful Prince Edward Island, and I want to thank the National Collaborating Center for Methods and Tools for allowing me to speak today. As I said, I've made some very simple slides to share my experience. And as Maureen has said, most of us didn't really have experience in evidence synthesis, the people that joined COVID-End. I've been a stay-at-home caregiver for 15 years, and I was looking for something that would be more meaningful, that would help me to use what I've learned through navigating my children's health challenges and other things in our life to input into research. And so COVID-End came along at a good time. I learned about it through taking a family engagement research course, and also being connected to people there who mentioned the Spore Evidence Alliance. And then this call came up for COVID-End, and I was thrilled to be able to apply. And then when I got a response to say that I had been accepted into the pool, I was very, very happy. And then we had the opportunity for training. But what I'm sharing with you today is actually the experience I had with partnering with NCCMT on a review. And I'm going to share a little bit of just through the steps and what I learned along the way. So as Maureen has spoken about, she talked about having a patient pool. And she also talked about this request form. I was sent a request form. And again, I'm a mom of 6 children, ranging in ages from 7 to 20. I was sent a request form for a rapid review with on what is known about parents' considerations for vaccine uptake for children and adolescents. So I'm not very far from the preschool aged vaccinations, and we're in the middle of adolescent vaccinations and such. So hopefully my perspective gave a lot to this review, and that's what I was told. So the topic of review, and then Maureen and others look around the patient partner pool, and they sent me this form and said, you're a parent, would you be interested? And I was like, absolutely. And so this matching to me was very beneficial. As I said, I live in Prince Edward Island. I don't know how I would have gotten connected otherwise, perhaps through some other channels, because I'm fairly active online, but likely not. So the next step for me was meeting, and actually I was meeting Sarah and being introduced to one another through an online meeting, and I was asked, we introduced ourselves, what our experiences, and I talked a bit about my lived experience and my experience with rapid reviews. So my lived experience is as I said, a parent of 6 children. I've had a child get ill after a vaccine. I've also, I'm going to share a story later on, and you will understand the nuance here. We've had to time vaccinations, but I've also grew up knowing that my uncle died of polio. So there's a little bit of context, and my sister has lifelong lung damage because of a whooping cough, a pertussis infection when she was an infant. So there's a whole slew of experience there. I've spent time online in groups where there's been various points of view around vaccination, and there's lots of contention there. My experience with rapid reviews, this was my first one, but I had that wonderful training that was co-designed by Janet and Maureen, and it was great to kind of take that training. It helped me to get the confidence I needed to do this. And that being said, not everybody will want to training. They may want to be involved as and learn as they go. So I was introduced to the topic, and I was given a timeline. And the timelines that Andrea had spoken about were very, very short. I was given a 2 to 3 week timeline, and then I was great. We're starting. And this was 3 days before the initial start date for this rapid review, this meet and greet. And then I waited, and I had expected to hear something. And so this may sound a little bit, maybe this goes to my lack of confidence, but it also goes to, I'm on the other end waiting, and it's my first review. I don't know what's going on. And it really wasn't that long. If I look at it, it was just over a week, but I had expected to hear back by now. And I'm thinking, and through my head, it's like, did it start? Why haven't I heard anything? Am I still a partner? And should I reach out to the lead researcher, who Sarah is the person I had talked to? And so I chose to do that, and they were great about getting back to me. But just a gentle reminder that communication, so if the timelines don't exactly match up, if you're going a little bit late, just say, we're just running behind, and communicate that clearly. And people in academia know that things don't always run on time, but patient partners may not understand that may think that timeline is fairly rigid and such. But we all have life experiences too. So this goes to having a contingency plan. And I got a lovely email with the review partway through saying I have to pass off the review. So this is illustrated here as passing off a box to one another, but also it gives you it suggests that you think about what if you're unable to complete that review. And that may be from a researcher point of view, it may be from a patient partner point of view. So the timing of this review is right at the end of May. So I have about a month before my children are out of school, and then the house becomes really, really chaotic. And it's really, really hard for me to actually maybe do this work when I have a lot of other distractions. I'm sure many of you are parents, and COVID has maybe taught people how hard it is to work at home and have to be the caregiver as well. So, and just, I always have a contingency plan. It might be a change in timing or other things, but also researchers think about your contingency plan too. So I was asked to identify themes and gaps, and somebody, I'm not sure if it was Maureen or Andrea, talked about the time that you had. It's so rapid, but you still need to give your partner time to review the data in order that they can identify those themes or any gaps that are there too. And so for us, this meant that when the handover happened to another researcher, I was given a partial review so I could see what data had been accumulated already. And that allowed me to kind of pick out some themes and see gaps. And it already set me up a little bit so that when I see the final review, I can see, okay, are the themes the same? Have they changed and such? But having that time to mull over them and put them in context, that was really, really important to me. And so part of what a patient partner does is putting that evidence into context. And I want to talk about the idea of nuance here and flexibility. I put in the preferred communication method after I emailed my responses to the researcher for this review. I got a lovely email back saying, you know, they're similar to what we've picked out. Can we meet? And so we actually met over a virtual environment, but that could have been a phone call. It could have been asking me questions over email. That sometimes there are people that like to write things before they send them off in an answer. Sometimes people like to chat. Sometimes people don't have access to virtual environments and might need a phone call. And I'm going to say listening is key. Something I learned a very long time ago, and I keep remembering, it comes up over and over and over, is communication is multifaceted. And I was advised that what I want to communicate, what I say should be what is heard. And even though we think we are heard a certain way, sometimes we aren't. Now, I want to share a story to share the nuance of this. So we're talking about parents' considerations for vaccine uptake for children and adolescents, and I invite you to go and read the review. But my son called me today, and this wasn't supposed to make it in here, but I think it really shows you the nuance. He called me today. He was very, very upset that I didn't give him permission to get a vaccine at school today that he was supposed to get. So as I said, we're in the middle of adolescent vaccines. He's supposed to get it. Everybody in his class but 3 got it. So he's feeling left out. And as much as I say I like communication, I really didn't sit down with him and talk about this particular thing, but I did stress that we can't get the vaccine right now. Now, the data would say, you know, this person isn't getting a vaccine, but the reality is my child is on a 3rd trial for a med for a specific condition, and some of the side effects of the vaccine and side effects of the medications overlap. So if he were to get a vaccine today and then he started to have headaches or stomach issues, which he's had with the 2 previous vaccines, the likelihood that he would probably stay on this med is much lower. So my nuanced story is I have to make that decision that he can't have this vaccine right now, but let's get through this trial, and in a month, we'll revisit that and see if we can get the vaccination through our public health unit here. We have a really great system here for vaccination. And so it is accessible outside of those other times that it's normally set up. In this particular case, it's set up in a school setting. So that just gives you a little bit of context. And then the last thing I want to share is to check in with your patient partner before you finalize the review. And so what happened, and we're all learning as we go, I got this lovely, lovely thank you acknowledging my contribution in the review. And it was wonderful. I really, really appreciated getting that feedback. And then I got a link to a final posted review. And I went on it and I read it. And I was like, okay, this is great, except I'm not sure I agree with this one sentence. And even if it's just maybe like these 3 words, what do I do? And at that point, I actually was like, oh, okay, well, what do I do? So I reached out to Maureen and she said, well, we can contact them, or you can contact the researcher yourself, which I chose to do. And it was easily dealt with and they were able to update it. But now, because of that, they have a final check where the partner reads through the finished review and at least read through that executive summary. So to make sure everything's put into context, what you've meant to communicate is what was heard. And again, the acknowledgement of contributions, as people have said, it can be various things, but I was really, really thrilled to get a thank you. I was privileged to be able to do some undergrad research, and it takes me back to the first time I was in the lab, and the very first thing I got to do was a literature search for a paper that was getting written, and I got an acknowledgement in that paper for doing that literature search, and that meant a lot to me. And it feels like that again, that it's nice to be acknowledged. So the lessons I learned, now this may seem, as I said, very simple and a first experience, and I had a little bit of training. I really appreciated that training. So also when I say I agree also that researchers need to be trained. I've done a lot more reading and patient engagement research since I was first in COVID and such, and interacted with other researchers, not on evidence synthesis work. And that training can be very beneficial, but not everybody is going to be formally trained. For me, there were more opportunities as part of that COVID pool, and timelines are approximate. They're fast, but they may be extended for unknown reasons. Communicate clearly, very, very important, because I might be thinking something totally different than what's going on. A final check before publication or submission is warranted, and it's good to have outside support. So that may be a patient partner that's more experienced. It might be other partners in the COVID pool for me, but for me, it was really reaching out to Maureen and Francois and saying, you know, I have this concern, how do I deal with it? And it's nice to feel appreciated. And that could be compensation, as was talked about already. It could be a thank you. And one of the things that my name was on the finished review, but I was really impressed was that I was asked if I wanted my name on that finished review. I might not, patient partner might not want their name on. I did. It was really, really nice to be acknowledged on that review. So I want to thank you for listening. And I think we're at the point of questions, but I'm sure Alana will tell us where we go next from here.
Wonderful. Thank you so much, Amanda. I see the chat lighting up with thank yous, and really, really appreciating your insights and thoughtful commentary on the process. Unfortunately, Abu is not able to join and share his perspective as well. So what we will do now is move on to the Q&A and discussion portion. So I invite our panelists to turn your videos on. And I will jump into the question section. I will actually start with the last question that came in, as it's the most related to the real focus of this presentation. We have a question from Ciara. I have struggled with how best to deal with projects where there are two involved and valued members who happen to have competing or conflicting interests with each other. Do members of the panel have insight on whether it's better to plan to hold group discussions separately to avoid conflict or derailing of the process? Or perhaps there are learning opportunities from this being an open group discussion? Does anybody have any thoughts on this question?
Well, I would like to ask Andrea and Maureen to comment. Maybe luckily NCCMT, I don't think we've come across this yet. So I don't think that we can actually, I don't think we have any learnings. So over to you, Maureen or Andrea.
Sure, I can jump in. So thanks for that question, Kira, and nice to see you there in Ireland. If it was two patient or public partners who had conflicting views, a lot of sensitivity has to be applied to that, because people are bringing their lives into this. And so, of course, you know, the biggest message is always, this isn't a debate. Patients don't have to reach consensus. They're there to give their perspectives. If those perspectives are different, that's great. But if you get into a situation where you've kind of tried to bring them together and that's not really understood, and there's someone who's kind of pushing their own view, I would definitely do it separately. You know, it's really important to have that safe space, and it's very, often very emotional for people. This is their lives, this is their life experiences. So I think that, in the cases that I've been in, except for a meeting 2 weeks ago, so I shouldn't say that, usually it's a safe space and people understand that it's not a debate. But if you do get into that, you have to stop immediately. You don't let it go on. You just stop it, and then you say, "We're not here to debate. All perspectives are welcome." If it's a researcher and a patient partner, the same thing would apply. We're really there to bring our lived experience, and no one should be judging that lived experience. And the researcher is there to bring their expertise, and we really shouldn't be judging their expertise either. It's kind of a two-way street. So I don't think it happens very often, but you definitely have to be ready with a plan so that it doesn't. So this meeting that I was talking about, I actually jumped in and said that I was going to be leaving the meeting unless they changed the facilitation and made it a safe space. And it wasn't really for me because I'm kind of toughened now, but I saw other people being really mistreated. And I just said, unless you make a change right now, this isn't safe. This isn't a debate. We should be able to say what we want. So I think that, you know, I think researchers are extremely sensitive, the people that I've worked with, to that. So I'll stop there.
Yeah, no, thank you so much, Maureen. I agree, of course, as usual, with everything that you've said, and very hard to add to anything you say. I would say that, you know, I have experienced you know, I've heard of some meeting, you know, maybe 1 or 2 meetings being derailed. And I think that even in the patient partner course that Maureen and Janet co-led, they mentioned, I forget how you phrased it, but not airing your problems or something in a very nice way that, you know, if you have some issues with the health system, not to kind of, maybe don't bring that up in the research meeting, which I thought was a helpful tip for everyone. So I have seen some patient partners not being happy, you know, with the decisions, or not being happy with the way things may be going. And so in that case, you know, I took the time to meet one-on-one, you know, with the Zoom camera, and I just sat back and listened and wanted to hear everything, and then, you know, offered support, encouragement, and tried to think of a way forward. I think it's challenging because we are coming from diverse perspectives and diverse experiences, and trying to bring kind of 2 worlds together. I think it's expected to have some clashing, and agree it's probably not very common. And most people are very respectful. And I think the approach that you said, you know, if it does seem hostile, to stop the meeting and, you know, addressing it one by one. And when I had the chat, like the one-on-one discussion, everything seemed to be resolved, and things have gone pretty smoothly. But it's important to note that these things can happen, and not to blame, and not to feel guilty, and you know, just thinking about how can we be supportive. So yeah.
Great, thank you so much. Again, we encourage anybody in the audience to submit your questions to the Q&A. We'll make sure that we answer as many as we can. The next question is more about the rapid review process. How do you deal with the scanning step? So scanning titles and abstracts. How can you rapidly perform this step with 2 independent reviewers?
So I can take that for our team. So the duplicate screening is one of the sort of shortcut steps that we do take in the rapid review process, as opposed to what we would do in a full systematic review. So we do have only 1 reviewer screening at the title and abstract level for most of our reviews. We use a program called Distiller that has an AI function that learns your screening as you go. Don't ask me to explain how, because that is way outside of my area of expertise. But it does flag studies that it thinks you have excluded accidentally. It's not perfect. It's probably not as rigorous as having 2 independent people go through, but just in terms of timelines, that's an extra double check that we have, an extra kind of safety net in place for missing studies. But that's one of the compromises that we make in the rapid review timeline.
Great, thank you. And another question about rapid reviews. What is the big difference between traditional reviews and rapid reviews, other than that the rapid reviews are completed in a very short period of time? The question asker assumes the amount of efforts in terms of the 2 review process methods would be similar or the same. Oh, Sarah, we can't, yep, there. We couldn't quite hear you.
Okay, I can start again.
Okay.
That's a good question. And Andrea, I might turn it over to you for your perspective as well. But I don't, to my knowledge, there's not, you know, one distinct definition or cut point or criteria for defining something as It's sort of a bit of a spectrum. So the idea with a rapid review are, as I mentioned before, there's some sort of little shortcuts or compromises that are made. So ideally you want to try to get as close to as possible that systematic review process. So, screening your titles and abstracts by 2 people, full text screening by 2 people, data extraction by 2 people, critical appraisal. And there are across all of those steps, there are different sort of shortcuts or compromises you can make along the way. So I think really the important distinction is making sure that whatever your team has chosen to do, you report that appropriately. So as you're reading through, you can appraise and understand what shortcuts or concessions may have been made. But that being said, I've seen systematic reviews published that take some of those shortcuts as well. So I think, I sort of think about it as a bit of a spectrum. Ideally, you want to get as close as possible to systematic review methods in a feasible timeline. But Andrea, I'd love your thoughts because we often cite your paper.
I mean, as usual, I completely agree, Sarah. So your answer is perfect, and I have nothing to add to that. Yep.
I can chime in on that one from a patient and public perspective. Huge difference between a rapid review and patient and public engagement and a systematic review. So I'm going to do a shameless plug of a systematic review that I've been the principal knowledge user is going to come out next week on decision aids. I've been working with that team for 2 years. There's flexibility, they can plan meetings, around each other's schedule. I got to know them. We started before the pandemic, because I remember we went out for lunch. So, and it's an international team though, but there's a couple that are who are in Ottawa. So huge difference. When we did the course, we had all these panelists come on who had participated in rapid reviews, and one of the questions was, how did the research team, adapt to your schedule? How do they accommodate your schedule? And the person answered 0. She was like this, 0 adaptation. Like it had to be done. We would get it within 24 hours. We had to respond. So it's completely different, and so it's the pressure for the rapid review is really there, and that's why my fingers were crossed. And the fact that we were able to do it has been pretty amazing, because I don't think it's easy on the researcher. I think the people who are like the patient partners and the public partners who are doing it, I think they're seeing that this is a really big ask to be able to do this, because it's a really fast process. So huge difference on the engagement side. So that's a really good question.
If I could just jump in as well with a couple of comments too, in particular. So one thing that we may want to go back and take a look at, and Andrea, you've done some work on this in the past, is if we did systematic reviews on some of the topics we've done rapid reviews on, how different would the results be? So I think that is a question. We've definitely been asked that before, and we probably should do some work to answer that. And Andrea, I know you were doing some work on that. So did that get finished pre-COVID, or do you have some insights on that?
Yeah, Maureen, you're not going to be happy with me. Maureen has been asking me this, I think, for like 8 years. Yeah, so you're right. So we did get CIHR funding to compare the results of a rapid review to a systematic review on the same topic. We did not engage. So Maureen will not be happy. The other Maureen, so Maureen Smith will not be happy with me that we did not engage patient partners. Actually, I think we did in a couple of them, actually. I take that back. So, but it wasn't for all of them. It wasn't mandated for all of them, although we did try to have knowledge users on, our decision makers on all of them. So I am pleased to say that the 13 systematic reviews and 13 rapid reviews are done. We're just wrapping things up, and we did like surveys and interviews with the decision makers to ask them how useful was the evidence, et cetera, et cetera. So please expect something next year. And absolutely COVID delayed it, and there have COVID plus there's been many delays on that project, but hopefully we'll get some results next year. Yeah.
That's really fantastic. Whenever they come out, they're going to be very, very very, very useful. And that's impressive, 13 of each. And I'll just make one more comment before welcome, Abu. It's great to see you, and we're going to turn the camera over to you in a minute and the mic. But the other thing I think we need to think about as well is I don't think the rapid reviews are going away. So if we want to keep our decision makers and policymakers engaged in using evidence, they have now become accustomed to asking and getting something very quickly. And I don't think they're going to go back to hearing, saying it's okay to say, well, that's 6 months, 1 year, 2 years for that review to be done. So with that being said, and knowing that, you know, there's many areas, chronic diseases, for example, that have thousands of studies, that rapid review process will be extremely challenging. But I think that there's great opportunity for us to be thinking about what is feasible post-COVID in terms of continuing to do these syntheses and how to best engage patient partners, hopefully in a way that isn't that, okay, we need you on standby for the next, you know, several days, and as soon as you hear from us, you have an hour or 1 day, whatever. Like, we need to really be thinking about how does this make sense for everyone to be involved, and still wanting to really learn from many around the world that have been engaging patient partners in all sorts of research to really learn and like co-develop what some of those processes should be in the future. So Emily, I'll turn it back to you.
Wonderful, thank you. Abu, so glad that you're able to join us. So we had just done some Q&A. There are still a few questions in the Q&A, and our presenters, you are able to type an answer if you'd like. But for now, I think we absolutely want to hear from Abu while we still have some time left in our webinar slot. So Abu, I will hand it over to you.
Thank you, Emily. Apologies, I had to do some catch up with technology here. You know, I'm privileged to be part of this webinar today, and I want to say thank you to Emily Clark for putting this together for us, and also thank you to Maureen, who have been very helpful in keeping me up to speed with whatever is going on. So really, when I got involved with this rapid review, there were several things that jumped out of me immediately when I heard about it. And because this review captured some area that I thought were very interesting, as well as I felt that there were also certain aspects of the review that did not reflect well on a particular demographic that I have interest in. And this demographic is the refugees and newcomers in terms of food insecurity. Because what really triggered my interest is mostly because the level at which the review itself was reflecting what was happening in terms of food security and the issues that sort of came out of that review. And because generally speaking, when you talk about insecurity, food insecurity or poverty, usually there are a certain demographic of people that come in mind automatically. And I felt that this demographic was not adequately reflected. One, second, and the way in which they were not reflected also mattered to me, because the way I thought would be helpful for researchers going forward is to engage this demographic from the community level, as opposed to doing it on an individual level where, you know, you can have individuals speak of their individual experience, etc. But the reason why I thought if it's reflected on a community level, it gives you a deeper and a more accurate sense of what is happening at that level, simply because there are segments of that or pockets of that segment that is usually not engaged, and there are reasons why they are usually not engaged. Now, if those reasons are captured in the research and act upon, then it will broaden the scope, and not only will it broaden, but it also reflects those issues that are the result of what has been keeping them aware, what is isolating them. And that's really what triggered my interest. And I thought with the rapid review going forward, maybe, and I can understand because this was a new phenomenon that we were experiencing. Nothing of this nature had occurred before. And so in the rush to capture, to sort of figure out how to understand the phenomenon, yeah, I can see why some of these things can be missed. But I thought I reflected on it, and I thought by bringing it to the attention of researchers and people who have interest, it would serve a very useful purpose going forward in the future. And the other thing was, once this is captured, now how do you reflect them in other social services, in other areas of social services? And by social services here, I really I have in mind social connections that is usually through community-based programming. Now, because usually newcomers, immigrants, and refugees like to stick to their own community, it's very challenging for them to assimilate for a variety of reasons. So if there are social programming that can engage them at their level, then it gives you a better sense of where the gaps are. And once you identify those gaps, it makes it a lot easier to sort of bridge those gaps because you have met them at their level and you have identified where those gaps are. And quite frankly, I reflect on myself as a person of a refugee background, a newcomer background, even though this has been 30, 35 years ago, but still is common among refugees to feel not belonging, either because of not being able to communicate, or multiculturalism is a new phenomenon to them, or some other reasons. But because if you overcome any one of those issues, then the path to that assimilation, the path to that becoming part of the larger community becomes a lot more easier. But you have to decipher those barriers, those roadblocks that are created, and actually in some cases they might even be artificial because of the players and people these individuals interact with. And so I thought overall the research was pretty good, except that when these aspects of the demographics that I'm interested in are highlighted in the future, and other research that might come along, it will serve the larger community to reflect. You know, somebody was saying one time during those one of those reviews, you know, usually disabled people and elderly people come in mind readily available because they are the ones usually at disadvantage, you know. So I just thought I highlight on these issues and concerns that I thought would be a lot more helpful to us and to the researchers and to the community at large. And I want to say once again, thank you very much, Emily, for giving me this opportunity to share with you what my views are.
Thank you. That's very, very insightful, and I think a really valuable perspective to be shared with this group. I'm really glad that you were able to join and share with us. Are there any other comments? I see we have gotten through our Q&A. Thank you so much for the answers, the questions that were asked and the answers that were typed in there as well. So what I think I will do now is start wrapping things up. We do have a webinar feedback form that we've built into the webinar. So in a few seconds, there should be a form that pops up on your screen that will allow you to answer some questions about the webinar, whether you felt that the webinar helped increase your capacity for evidence-informed decision-making, whether you will apply some of the information that you've learned today in your own practice, and some thoughts about how the webinar was facilitated and presented, and the technology that we used. So we'll wait just a couple of seconds for participants to record their answers. I do see those are coming in now. Thank you so much for that. I'll take another minute again to thank our panelists for their perspectives and taking the time to join us today and put together some really fantastic slides. We look forward to getting those posted online and the recording as well. I think we've heard some very, very valuable perspectives today, and we're really glad to have had everybody join us today. So that's great. I see, looks like most people have had a chance to respond. Just make sure that you hit submit at the very end. In wrapping up, if you are interested in more webinars from the NCCMT, you can visit our webinar page. The link is on the screen, and we'll post it as well in the chat window. So you can check out any other upcoming webinars that we have. Notably, next week, we will be having a webinar presenting the award, the winners of the Knowledge Translation Graduate Student Awards. This is an award presented by the National Collaborating Centers for Public Health, so all 6 of the NCCs, for some really outstanding and equity-focused graduate student projects. And those will be presented next week at a webinar as well. I can direct you for the NCCMT. Our website is nccmt.ca. You can email us at mcmaster.ca if you have any questions. As well, if you have any questions for any of the panelists, feel free to reach out with us and we can get you connected as well. And I will invite, I would like to thank again our panelists and our audience for joining us today. And I will ask our panelists if they have any closing comments before we wrap up.
Thanks, Emily. I actually have a question for primarily Maureen Swip-Smith, but Andrea, feel free as well to comment. I'm wondering what you think is needed in order to be able to maintain this cadre of patient partners that can be accessed to support rapid reviews into the future. Because I was just writing that in the chat that without your support, both yours and Andrea's, to quickly go out to the network to find partners that could help us on topics that were of relevance and importance to them, we would not have been able to include them. So what do you think it's going to take in order to be able to have something like this kind of ready on the go for when it's needed?
Yeah, that's a really good question. I think I can do a parallel. When the pandemic started, the Cochrane put together a rapid response consumer network, and 118 people signed up, and we made a couple of videos on rapid reviews and, like just a few things, but I don't think, I think 28 people got called, and it was mostly peer review at the end. So the old, systematic review approach, nothing like what we've done, that I can guarantee you. So how come we were able to do it? I think a lot of it was just that commitment. So COVID-N was committed, Andrea was committed. We worked together. Like I work with Andrea's team all the time. Like last week when Emily contacted us and said, do you have someone? We looked, we're going to contact Andrea Wasifa and Andrea right away. And we just kept working together. So I think the collaboration within Canada, and we tried to push some of it out globally. So we tried to create some resources globally. It's extremely difficult because everyone has their own context. But I think that we have to be proud of what we have done in Canada, and we've got to continue that commitment. And then when we do the rapid, we go back to, more systematic reviews, we have to be able to say, look, if you can do it for rapid reviews, don't tell me you can't co-produce systematic reviews. Like, come on, we did this in 2 weeks and you've got, 14 months to do it. So I think we've probably moved the needle. The thing is now is that all we're doing is trying to keep up. Like we get requests, and we haven't really had a chance to really sit back and think, okay, what happened? What did we do? But it's definitely the collaboration. Like there's no way any of this could have been done. And I've made friends. Like I'm like, oh wow, these new friends that I'm collaborating with. But I think it was a very personal, it's like a personal touch, like, and going on and always to researchers, hi, I'm here, I'm willing to help you, just contact me, I'll help you, and you know, being sincere about it. But so I think it's really, if you compare it to what happened at Cochrane, whereas maybe it's not as personal, it's emails going out, I think that's what made the difference, and having that small context, because it doesn't work in all contexts, but it worked in Canada, and our partners are from all over Canada. So we're very proud of it, but it really is committed people who believed it and who pushed it. I couldn't do it on my own. I had the passion for it, but I don't have the power to do those things. I need to work with you and with researchers who are willing to try it. And I think it was, yeah, I think that's what it is.
That's great. Thank you so much, Maureen, for sharing that. That's been wonderful. So we are just about at time. So thank you so much to everybody. Really appreciate everybody joining us today. Hope everybody has a great, excellent rest of today, and hopefully see you at one of our upcoming webinars. Take care, everyone.